So we'll now begin with the fourth session, that is Portal Hypertension 1, and we have one speaker. Uh, I would like to invite the chairpersons for this next session. Uh, Dr. R.S. China from Fortis Hospital, Ludhiana. Dr. Amar Mukund from ILBS, New Delhi. Dr. Mattis Mandorfer from Vienna, Australia. And Dr. Naveen Kanju from Aster Group of Hospitals, Bangalore. Over to you, chairpersons.
A very good afternoon. After a sumptuous lunch, it is very difficult to keep your eyes open because of the hyperglycemic rush of blood which happens. We, anyway, have a very learned speaker, Dr. Sanjeeva Kalwa. He is the Vice Chair of Image Guided Interventions, Department of Radiology from Texas, US. Generally, what we had heard about Texas was the cowboys. Yeah, so we are going to hear something about portal hypertension, the radiological management. Over to you, Sanjeeva Kalwa, please.
Thank you so much. And first of all, thank you for inviting me. I really appreciate the invitation. It's my first visit to INASL meeting and my second visit in my life to Chandigarh. I really enjoying it. Thank you. In the next 15 minutes or so, I'm going to provide some concepts that we use as interventional radiologists when treating portal hypertension. For each concept, my first statement, the title will be written, the concept, and I'll explain to you what the concept is and why we do that way. I hope it is useful for you. So portal hypertension, we all know what portal hypertension is, and the treatment generally falls into two categories. Number one, when the patient becomes symptomatic, you treat symptoms. It could be a patient has esophageal variceal bleeding or ascites, you do banding or sclerotherapy or tap the fluid. Or you can also consider doing embolization of the varices. Here, the primary focus is to treat the underlying symptom. And the main disadvantage of this therapy is that the portal hypertension remains unchecked and continues to rise. Whereas you can also consider targeting the portal pressure to reduce them so the symptoms won't occur. So those portal decompression procedures include surgical shunts, TIPS, or splenic embolization. At least the first two of these will cause hepatic encephalopathy. So whatever we do has a balance. Either if you consider treating symptomatically with sclerotherapy or paracentesis, you're not treating the underlying primary problem. If you decide to treat the primary problem, you end up causing hepatic encephalopathy. So your choice of treatment depends on where the patient is in this stage and tailor the treatment according to the patient condition. So how important are portal pressures? Number one is it helps us to diagnose, but more importantly, we know when they can develop symptoms and what level they can become so bad that we really need to consider portal decompression techniques. Especially when you go to 12, 16, and 20 levels, they need to get treatment in terms of portal decompression. Whereas when they're at a lower level, you can manage them symptomatically with sclerotherapy or ascites tapping. How do you measure portal pressure? It's measured with a balloon occlusion catheter placed in the hepatic vein. You obtain a free hepatic vein and the balloon is inflated, and you inflate the balloon proximally in the hepatic vein, confirm the inflation is sufficient that there is no flow going into the hepatic, or flow is not coming back into the heart, and then measure the pressure. That pressure is called wedged hepatic vein pressure. The wedged hepatic vein pressure is the portal vein pressure because the hepatic vein distal to the balloon has a continuous column of blood into the portal vein through the sinusoids. So what you get as a wedged hepatic vein pressure is the true portal vein pressure. But it works only if those sinusoids, the entire tract is patent. If there is a thrombosis there, then it doesn't represent the true portal vein pressure. And once you get them, you subtract the wedged hepatic vein pressure from the hepatic vein pressure, which is the systemic venous pressure. Do not obtain the systemic venous pressure from the right atrium. Always obtain from the hepatic vein. If you can't get the pressure hepatic vein, get from the or intrahepatic segment of the IVC, which is equivalent to hepatic venous pressure. And we know where it increases, where it decreases. Classic and cirrhotic, It's usually elevated, HVPG elevated. Almost all the data we present is based on the central sinusoidal port hypertension. If you do pre-sinusoidal or post-sinusoidal, none of the guidelines are accurate. They don't apply to those treatments at all. All the guidelines apply only for the sinusoidal portal hypertension. There are other things you can think about it. There is an increasing push to diagnose portal pressures through non-invasive methods. The initial studies focused on liver stiffness, the fibroscan, or all these things. They also tried on T1, the time, the measurement of the time for the MRI sequence for the liver, and to see whether they can correlate to the portal pressures. And they did show some correlation, but it hasn't come to the mainstream level. Similarly, splenic stiffness is also measured and correlated with the portal pressures. And they have some correlation, not to the extent that you can replace the portal pressure measurements directly. There's a recent one that is called a 4D 4D angiography, where you can see the flow pattern in the portal veins, splenic veins, and the branch vessels. So the minute you see branch vessel opacification, that means the portal pressure have gone to the level that there's a recirculation happening through collateral pathway. So let's move on to interventional therapies. Interventional therapies are first and foremost portal venous decompression. This decompression procedure is TIPS or splenic embolization. Initially, splenic embolization was very popular among surgeons. However, now it's rarely practiced, and we have done a few of those cases. It doesn't really change this portal venous pressure that much, maximum by 2 millimeters of mercury. So it isn't that effective in treating portal pressures. However, it could be combined with other procedures to help you. We'll talk about it later. TIPS is the modality of choice if you really want to decompress the portal venous system. In a prehepatic portal venous occlusion or extrahepatic portal venous occlusion, portal venous reconstruction with or without TIPS is very helpful to reestablish the flow and improve the hepatic function. In case of post-hepatic obstruction or post-sinusoidal disease like Budd-Chiari, hepatic veno-occlusive disease, or IVC-Webb, one could consider opening those veins to establish flow. And after that, you can also consider embolization of the varices itself or portosystemic circulations. For example, gastrorenal shunt or mesenteric gonadal shunts. You can embolize those things. When should we embolize them? When the patient has symptoms and also has severe encephalopathy where TIPS would not be beneficial for those patients. These include antegrade. The word antegrade indicates you are going through the portal vein to block these varices. That is called antegrade. Whereas the word retrograde is used that you are trying to treat the varices through the systemic venous approach, such as renal venous system or infravena cava that connects to these varices to different collateral pathway. Those among these different types of retrograde obliterations, what's called BRTO, CRTO, PRTO, these are nomenclature. You don't have to remember any of these things. All you are doing is systemic venous approach to treat the varices. That's all you're talking about. You can combine it with the TIPS or you can combine with splenic embolization. Why? The minute you occlude these variceal complex or the shunt that are physiologically formed to decompress the portal system, you are bound to increase the portal pressure. So you need to develop some other technique to reduce the portal pressure. That could be a small diameter TIPS or splenic embolization to reduce the portal pressure enough so that you won't develop the post-embolization hypertension. Make sense? So next one, the TIPS. TIPS is always performed from hepatic vein to the portal venous system. It could also be performed from the IVC to portal venous system. Personally, we prefer in our practice doing a TIPS to the left portal vein than to the right portal vein because the incidence of hepatic encephalopathy cuts by 50% if you do the TIPS to the left portal vein than to the right portal vein because right lobe of the liver is big, left lobe is small. So the direction of flow, there's some flow still preserved to go to right lobe for metabolic functions of the liver. So if somebody could do a TIPS, always aim to do a TIPS to the left portal venous system. At the end of the TIPS, the portal venous pressure should be brought down to 12 or less, or at least 50% what it was to begin with. That's the aim, and that's the goal you should always target. There's no controversy now that you must use covered stent. I know India doesn't have it. I think the GORE is coming by this December or by the next March. They're reintroducing the GORE Viator graft. If the Viator graft is available, you should not use any other graft. Viator graft is the FDA-approved device. It has a special membrane in the graft material that prevents bile accumulation to the stent. So we always use that. It has higher patency compared to bare metallic stents. Always use image guidance. At the US, we use intravascular ultrasound, which is called ICE or intracardiac echocardiography, which clearly delineates where the portal vein is. For example, in this case, this is the right hepatic vein, this is the right portal vein. It's extremely easy to do the tips. My trainees do it one single stick. Right? It's so hard for me to train the trainees because they don't, second chance doesn't exist. First chance they're getting in the portal system. So once you develop the skill set, in India, many people use just diagnostic ultrasound from the abdomen to do the same thing. They do improve the outcomes. They reduce needle passes, they reduce complication, they reduce the room time, they reduce radiation dose, they reduce the contrast use. Always it is better. Even this recent study has shown if you use image guidance during the TIPS procedure, it does help to reduce the post-procedure enzymatic elevation. Use 8 millimeter stent, not 10, not 12. If the post-procedural pressures do not come to 12, don't bother. Stop at 8, send the patient home, bring him back a month later, repeat the pressures. Because the pressures post immediately the tips are not accurate. The reason is that your patient is under general anesthesia, the pressures are out of whack, they have a hypotensive already to begin with because of general anesthesia. The post-procedural measurements of post-PSG gradient are never accurate. So bring them back again a month later and repeat the pressures under no sedation, no anesthesia, under general. That will provide a better understanding. Or better, wait until the patient develops symptoms. The patient is asymptomatic. You don't have to treat to make it to 10 millimeters of stent. So we always do 8. 8 has shown to be equally effective compared to 10 with a significant low incidence hepatic encephalopathy. Now we are pushing, can you bring it down to even 7 or 6? So as small as possible tips so that you can reduce the pressure but do not cause hepatic encephalopathy. Coming to varicose bleeding, it's no-brainer to use tips if the patient continues to bleed despite endoscopy therapy, where it's called salvage, or you just sclerose the varices and the patient bled immediately within 72 hours. That is called rescue tip. Within 72 hours, you're doing it. You treated the patient went home. After a month, you're doing tips to prevent secondary bleeding, secondary prophylaxis. The most controversial is the preemptive tips, meaning, well, I got control of the bleeding with endoscopic therapy. Why should I get the patient to do tips? The reason is, in select patient, it does improve survival. So this is a paper published in NEJM long time ago. What it does tell us is, it improves the 6 months or 6 week survival and 1 year survival if you do early tips. The word early tips is used by this paper, but the new AAC guidelines change the word early to preemptive tips. Preemptive tips means patient has resolved bleeding, but is at risk of bleeding, the risk being patient is child C or child B with active bleeding on endoscopy or HUPG is more than 20. So any of these are positive, you should proactively go and do tips in those patients. If you do see varices after the tips creation and the indication is bleeding, you must embolize the varices because embolization would improve recurrence rates. It will decrease the recurrence rates. It will not have any effect on the survival or encephalopathy or any other outcome. It just decreases the incidence of bleeding. You might say, why bother about it? It is bothersome because it reduces the unnecessary use of resources in the hospital, unnecessary use of resources of the society. So you should embolize when the patient is with you so he doesn't have to come back to hospital every time with the bleeding. We can use coils, which is not a very preferred method of embolization, but probably works okay for esophageal varices. But in case of other varices, always use liquid embolic materials. Why? As you could see in this picture, esophageal varices are fed by one single vein, which is this vein, which is left gastric vein forms the esophageal varices. But when it comes to gastric varices, that's fed by multiple left gastric, short gastric, posterior gastric. All these veins feed into the gastric variceal complex, which ultimately drains into the phrenic vein that drains the renal venous system. In those cases, you must embolize the variceal complex itself. It acts like arteriovenous malformation. If you don't do that, they're going to come back. So that is why in in addition to TIPS or in lieu of TIPS, people try to do what is called retrograde transvenous obliteration, where the focus is to go and treat the variceal complex with sclerosing agent. We talked about the main problem with the TIPS is encephalopathy. Main problem with the venous obliteration is worsening portal hypertension. It's a case I have done long time ago. Is the endoscopy showing large varices. We did the venous obliteration, and post you can see complete obliteration of varices. It works beautifully well compared to TIPS or even TIPS with embolization of the varices with the coils. RTO is very, very good in complete obliteration of the varices, no rebleeding, but 40% chance of ascites, 40% chance esophageal varices. So RTO is not great procedure. It does cause increased portal hypertension. It does cause downstream effect. So be careful choosing it. We have I'm done. So, okay. So overall outcomes, if you look at the hemostasis rates, both are similar. So if you were to choose, a patient came with gastric variceal bleeding, is bleeding to death, what would you choose? You don't choose BRTO, you choose TIPS. The reason is TIPS allows you to embolize the variceal complex and also decrease the portal hypertension. TIPS has been shown to be more effective than any other procedure to reduce portal pressures. So don't do BRTO just because patient gastric varices. You have to decrease the portal pressures. So the complication rates are slightly higher with BRTO because technical challenges the procedure. TIPS, many people have done it very well, so it's usually less complicated. Hepatic encephalopathy is the problem with the TIPS all the time. So in this particular patient has severe encephalopathy and a bleeding. So what we did was embolize the variceal complex with a splenic embolization as well to reduce the portal pressure. So all the varices are gone, no more encephalopathy in these patients. So what do I recommend? This is what I recommend. If the patient has a high portosystemic gradient, low MELD, no encephalopathy, mainly esophageal bleeding, do TIPS. May not combine with the variceal embolization. If the patient has mainly gastric varices and low MELD score, mild hepatic encephalopathy, still consider TIPS and embolize the entire shunt. If the patient has severe encephalopathy and a very high MELD, more than 19 MELD, then go and obliterate the varices only. Yes, you're taking a chance the portal pressure will go up, but you buy the time, because by the time some improvement in MELD occur, then you go back and do the TIPS in 6 months or a year later. PVT is no longer a contraindication. You can create TIPS even there is a portal vein thrombosis or acute or chronic, especially chronic. Why should we do that? It will make a transplant very easy with a natural anastomosis. So it's a case I have done with the extensive periportal collaterals. This patient presented with portal biliopathy and bleeding while exchanging the biliary stent in an endoscopic suite. He was started on a Belmont protocol, like a trauma, major vascular injury, and came to myself with the 12 units of blood transfused, and we get the TIPS immediately on this patient. So we can do that. And technical success is close to 100%. 1 year patency is 80%. 1 year survival is 90%, major complication of 10%. It requires some training and some skill set. I'm sure many of the major hospitals in India can do that, and we are happy to help them, those who want to learn. You're welcome to come to my institution and learn from us, and we can have you for free of cost. TIPS is very well known for ascites. It improves reaccumulation of ascites, but it also improves transplant-free survival as known before. And there are other indications, including Budd-Chiari, portal gastropathy, hepatic hydrothorax, hepatosplenic syndrome, ectopic varices. Portosystemic shunt embolization is considered in patients who present with hepatic encephalopathy. So this patient who had a very huge mesenteric vein to glomerulus on the right side, splenic to glomerulus venous shunts on the left sides, which are successfully embolized to reduce the portal pressure. In another patient, this is a patient of mine who has a humongous portosystemic shunt in the pelvis, when inferior mesenteric vein, intrailiac venous shunt, there was no portal flow at all. In this patient, I first created a TIPS, because if I accrue the shunt, where the portal venous blood flow would go? They call it whole thrombosis. So we create a small TIPS to embolize the big physiological shunt. Yes, you reduce the encephalopathy in that process. So in conclusion, portal pressures are key for treatment stratification. TIPS has superior outcomes. Main drawback is hepatic encephalopathy. Always consider small diameter TIPS. Varicose embolization is key for gastric varices. It may not that much important for esophageal varices. Other vascular interventions are very effective for Budd-Chiari and extrahepatic portal venous occlusion. Splenic embolization is not that much favored, mainly because it doesn't decay the portal veins as you think it would. Combination therapies are key, where we would try to consider putting a 6mm tips in the future and embolize the variceal complex. So that's where we are going. We have a new trial going on with a 6mm, 7, 8, 9 dynamic tips diameter stent coming from the board. We are part of the trial. I hopefully the results will come soon. Thank you so much. I'm sorry I took more than 3 minutes extra, but thank you.
So thank you very much for this very insightful and comprehensive presentation. I'm sharing your love for the tips as an interventional hepatologist. Possibly just to put a little bit into context, because this has been so enthusiastic. I think, Tangswin, that it's important to point out tips is always a treatment for complication with some exemptions. So it is always ascites as the complication, which is the most common indication for tips in Europe. Then it is always bleeding that has already happened as a complication. And the few instances where you can consider tips in a patient without complications would be, for example, a PVR tips ahead of a transplant to allow for a physiological anastomosis. Otherwise, I can't really think of indications for a tips in a patient without complications. Right?
Agreed. You don't have to treat a patient when the patient is not symptomatic. At least one symptom has to be present before you start treating the patient. So
I also absolutely agree with your, let's say, reluctance to emphasize a lot on portal pressure targets, because you're always treating the complication. And I think this underdilation tips concept is very promising. So we'll see where that goes, because looking at tips as a disease modifying treatment with these less aggressive approaches and the, let's say, a la carte treatment of the patient with a step-up approach, this could be really a very safe and still impactful intervention. So coming back to the obliterative therapies, BRTO, I mean, you already alluded to the discrepancy between the patients that you would assign to a TIPS and the patient you would assign to the obliterative therapy. Is there any aspect in the management that is very important after obliterative therapy, thinking of the potential increase in portal hypertension? So how do you handle this increase in clinical practice?
That's a good point. So whether you do TIPS or don't do TIPS, all these patients are already non-selective beta blocker therapy. So after TIPS, if you are unable to reach the expected desired portal systemic gradient, those patients should always be on medical therapy to reduce the portal pressure as much as possible. So after retrograde transvenous obliteration of varices, we know it will cause increased portal pressures. So one thing we do all these patients is put them back on beta blockers. Second thing is we do more proactive approach to the endoscopy to look for early signs of esophageal varices. And we also tell the patient monitor the weight to see if ascites is accumulating or not. If these things happen, a honest discussion to say whether we should create TIPS now or not at some point, or go for transplant at that point of time.
So we can allow one question from the audience if there are any.
Thank you, Dr. Kalwa. Regarding the left-sided tips which you proposed, I mean, my modern standard of care is right hepatic vein to right major portal vein, and the left side obviously is more challenging technically. So it all depends on the portocable gradient rather than the siding.
Then
Left-sided versus right-sided.
yeah,
Quantum of shunt is dependent on portocable grading rather than the side. So do you propose a new standard of care?
So you're right, absolutely right. So the right to right came because it was technically possible for interventional radiologists. When we were doing blind, I mean, what I meant to say blind is where we do CO2 portography by occluding the hepatic vein, inject CO2 that will go into the portal venous system, that will help us to identify where the portal vein is and stick the needle from the hepatic vein to portal vein. So during that times, we didn't care which hepatic vein we are in. Just go and get some portal vein and do it. So we never proactively touched left portal vein. The left portal vein is fought with more complications because left hepatic artery is very close to portal vein. This liver is very small on the left side compared to right. So more likely to do transgression of the capsule to cause bleeding. So that is why we never did left. We always did right to right, safest for us, long needle passes, you don't cause capsule perforation. With introduction of the intravascular ultrasound guided tips, now we are more able to see the left portal vein is very close to middle hepatic vein. So all our tips now is middle to left or middle to right, because middle hepatic vein lies exactly anterior to the IVC. With the ultrasound probe placed here, I can see the middle hepatic vein left on this side, right on this side. I can see which one I have to go to get the easier tips. The shortest possible, the straightforward, least complication, the tips we do it. So that's what we do it. If it is technically feasible, try to do left. If technically not feasible, stick with the old phenomena. Ultimately, gradient make a difference, but there's one paper published that which shows significant decreased incidence of hepatic encephalopathy if we do tips more into the left side.
So, thank you so much, Dr. Kalwa, for your excellent presentation and excellent explanation for right versus left tips. And indeed, it's very intriguing, like how to do, because it is left versus left, middle versus left, and right versus right. So yes, lot many steps to be done. But for today, I think we have almost reached to the end of this discussion. And I thank everybody for being here, and we move to the next session. Thank you so much.
Thank you.
So with that, we come to an end of this wonderful session. I would request the chairpersons and the speaker to please come on stage for a group photograph. And this will be followed by the second session on portal hypertension.